Hello all, I am Dr. C. Suresh, Assistant Professor, Department of Oral and Maxillofacial Surgery, Vinaya Mission, Sankaracharya Dental College, Salem. So I am going to take today classes at local complications of local anesthesia. So local complication associated with the two things, local complication and systemic complication. This broadly we can divide in the complication of local anesthesia. So today we are going to see brief about local complications of local anesthesia. So there are 13 local complications there. Needle breakage, persistent anesthesia and paresthesia, facial nerve paralysis, ocular complications, trismus, soft tissue injury, hematoma, pain on injection, burning on injection, infection, edema, sloughing of the tissue, post-anesthetic intraoral lesions. So we can see one by one briefly. So needle breakage. So patient coming to the dental treatment, everyone having more fear. So we are very cautious while using the local anesthesia syringes. So causes for the needle breakage is sudden unexpected movement of the patient. That is very important because all the patient in the dental chair they have more fear. So that time we are very cautious. We want to tell the patient about local anesthesia syringes, what injection you giving. So it's not a more pain, it causes everything. Then only patient having a no fear. So still some patient having some fear. So that's why the patient unexpectedly moving. Another causes for the needle breakage is needle of the smaller gauges. That is maybe main causes. So how to prevent this needle breakage? So we want to use larger gauge needle, long needles, use of long needles. Don't insert the needle into the tissue into the up to up unless it's absolutely essential because it's very weaker part is up region only. So we using very short needle. Want to, for example, in prealveolar nerve block, we want to go for up to 20 to 25 millimeter. That time we using a very short needle. We want to use full length of the needle inside the tissue. That time is maybe easily breaking the needle in the up region. So we want to use the long needle. That is very important, long needle. And also don't redirect the needle into once insert into the tissue because we after insert the tissue we redirecting means what happen means the needle may be very weak, so easily breaking. So we want to avoid this. So once breakage happen means how to manage. So once needle breakage happens, so want to doctor we doctor want to remain calm and don't be panic. Otherwise patient may be getting more fear of maybe going for wrong treatment. So you doctors want to be calm and don't be panic. Then also instruct the patient not to move. If the fragment is visible, try to remove with a cotton plier or small hemostat. So that's why patient must don't be move. Otherwise the visible part may be disappear inside the muscle. If the needle is lost and cannot be retrieved, so do not proceed with the incision suddenly. So calmly inform the patient and also attempt to allay the fear. Note the this instant into the patient record. That is very important. If the needle is superficial and is easily located through the radiological or clinical examination, then remove with a competent oral surgeon if it is possible. If needle is located very deep tissue or hard to locate the permitted, so remain it without attempt to remove. So it's so main thing is if visible we can attempt to remove the needle by using the hemostat or cotton plier. If superficial or deep superficial region, you can call on oral surgeon and remove with him, okay, with assistant. Then it's a very deeper portion, please don't attempt to remove the needle. So this is the radiograph OPG reveals where is the needle is breaking first one. So second one is very deep. First one is somewhat superficial, upper one, lower one is a very deep portions. So if attempt means very difficult to remove. So if the superficial things extraorally go and putting incision and retrieve the breaking needle. So this is the first one is over. Second one is a persistent anesthesia or paresthesia. Paresthesia is depend as a persistent anesthesia. So anesthesia will begin the expected duration or altered sensation will begin the expected duration of the anesthesia. So for example, lignocaine anesthesia, lignocaine hydrochloride with atolin is 180 minutes as a duration. Begin that patient is still having the numbness, means this is a paresthesia. So what are the causes for the paresthesia? Trauma to the any nerve. So our target is a nerve only. So that time we may be directly hitting the nerve, maybe causes the trauma to that nerve. injection of the contaminated local anesthesia solution. So our local anesthesia solution which will inject, that may be contaminated, so that we want to observe, see before the injection of the local anesthesia. Trauma to the nerve sheath, we directly hitting the nerve into the by the our injected needle, that may be causes the trauma. And also nerve is not coming along a lot of places, so it's coming along with the vessels, artery and vein. So that's why we are telling is a neurovascular bundle. So our aim is targeting the nerve, but sometimes our needle is hitting the not only nerve, sometimes is hitting the vessels. That's why the bleeding from the vessels causes the edema and local hemorrhage. So these are the things causes the compression of the nerve in that small spaces causes the paresthesia. So how to manage this? Generally we resolve, it will be resolved within 8 weeks. So within 2 months it will slowly resolve. So we want to observe the patient without any treatment. If the damage of the nerve is very severe, then paresthesia may be permanent. So according to the nerve injury, it may be happen. So small things is resolves within 8 weeks. So some damage is very severe only, it's a permanent. So then next is a facial nerve paralysis. So main causes of the facial nerve paralysis is the transient only. So transient facial nerve paralysis. How it's happened is introduction of the local anesthesia solution into the deep lobe of the parotid gland. So but it's mainly happen in the inferior alveolar nerve block technique. Because while giving the inferior alveolar nerve block techniques, our target region is lingula, is inferior alveolar nerve when it enters to the mandibular foramen. But what happened means a lot of people doing wrong is, so is opposite premolar region only our barrel of syringe want to keep, but sometimes is going not eating the bone. So a lot of people bring the barrel of syringe into the more anterior, so to eat the bone. That time is maybe your needle tip is going to more posterior, eating the deep lobe of the parotid gland. So it's like a lot of people like nicely aspirated and deposit the solution. That solution causes the transient facial nerve paralysis. So what are the things happen once you depositing the deep lobe of the parotid gland means? So loss of motor function to the muscles of facial expressions. So one side of the facial expressions are gone. So minimal or no sensory loss or unilateral facial paralysis is happening. These are the things happening while giving the local anesthesia solution to the deep lobe of the parotid gland. So once happening means what we want to do, so management. So reassure the patient, because first you want to know, because it's a transient, because up to local anesthesia action is there, that time only patient having this temporary paralysis. After that it will recover. So we want to reassure the patient, advise the patient to periodically close the eyelid, because the patient unable to close the eye fully, that affected side. So we want to educate the patient to do the exercises, okay, periodically close the eyelid. Then patient having the contact lens, it should be removed. Then record the incident in the patient chart. So patient record this incident into the patient case sheet. Then ocular complications. What are the reason for causes this? Diffusion of the anesthesia drug through the myofascial spaces or bony openings. So through the bony openings is going to the emissary veins. Lot of emissary veins is mainly is there. So mainly in the maxillary nerve blocks it's happening. So inadvertent intra-arterial or intravenous injection of the local anesthesia solution. For Gauguet's technique, that time it may be intravenously or intra-arterially sometime we giving. So it is a retrogradely going to the emissary vein, it causes a lot of complications. So otherwise sometimes direct trauma of the periarterial sympathetic plexus. These are the causes for the ocular complication. So what are the clinical features happening? So patient having amaurosis, blindness sometimes diplopia, otherwise devolution, endophthalmitis, globe penetration, Arnold syndrome. So patient having a blepharoptosis, meiosis, anhidrosis, hemifacial flushing, conjunctival injection, and anophthalmos, impaired visual acuity, patient having devolution, mydriasis, so dilation of the pupil having ophthalmoplegia, internal or external or partial or total, it may be. So patient may be having a ptosis or strabismus. So it may be convergent or divergent. These are the features patient having. How to manage? So patient having these are the features, you want to consult with the ophthalmologist. This is very important, because ophthalmologist want to consult, they want to give the opinion. So after the where is the uncertainty as to causes. So we want to refer the patient for ophthalmologist opinion immediately. Then we want to wait and observe policy approach. It is recommended because supportive measures are reassurance and patching of the affected eye may be advised. So we want to reassure the patient and also supportive measure want to give. So up to local anesthesia solution action that these problems having. So we want to wait and observe the patient and also we want to give some supportive measures with the patching of the affected eye to protect the eye. Trismus. And trismus is otherwise called as a prolonged muscle spasm of the jaw muscles by which normal opening of the mouth is restricted. So this is the definition. So the patient having not having the normal mouth opening. Because of the other causes for the trismus is trauma to the muscles or blood vessels in the infratemporal fossa. While inserting the needle, maybe your needle may be penetrating the muscle fibers that getting the inflammation. That's why patient having a trismus. Main muscles of mastication is very important. That muscle causes some injury means patient getting trismus. So reduced mouth opening they having. So irritation of the tissue. So our local anesthesia solution may be pH is very low sometime with adding the atoline. So it may be causes the tissue irritation and also hemorrhage. Already I told while bleeding from the vessels coming, the small space only potential space, a lot of spaces, that space getting compressed. So that compression causes the muscle also, so that particular muscle also getting stretched. That's why patient getting trismus. Sometimes low grade infections from the some tooth region, tooth roots may be passes the infection. Excess volume of the local anesthesia solution also. So all the space having some particular volume. More than that particular volume, we giving the anesthesia, that space getting muscles are getting stretched. So it getting trismus. So that's why proper anatomy, proper volume of the anesthesia solution and everything is very important. For example, we giving imperial nerve block, we don't enter by the giving in the middle pterygoid muscle. That is very important muscle for the open muscles of mastication. So that may be causes the trismus. So how to prevent this trismus? So you want to use the sharp and sterile disposable needles. So very sharp needle causes minimal trauma to the tissue. And also sterile disposable needles, so it prevents the infection. Clean the site of the injection with the antiseptic solution. Before the injection, you must want to follow the antiseptic protocols. You must want to clean this area, needle entry area, by the antiseptic solution. Then practice atraumatic incision. So atraumatic incision means we want to know the correct anatomical landmark, anatomical target region. Then why only one single incision. We reaching the target, so avoid the multiple incision. So avoid the repeated injection. Already I told, use minimal effective volume of the local anesthesia solution. So avoid the more volume means that potential space is having that much space. That okay. And also if onset of trismus happen 1 to 6 days of the post operative treatment period they are having this. How to manage? So we want to manage by using heat therapy. So heat therapy and warm saline rinse also want to give, then only is giving the more vascularity that region. So healing process very fast, the muscle everything getting more healing process. And also we want to advise the analgesics for the pain purpose, and muscle relaxant also we want to advise like a diazepam 10 milligram. And also we want to give the more physiotherapy. So physiotherapy and by using the chewing gums also for muscles getting relaxed. So we want to must give the physiotherapy. That is the main treatment. And also warm saline goggle. So next complication is hematoma. So hematoma is nothing but effusion of the blood into the extravascular spaces. So our target is a nerve, but nerve is coming as a neurovascular bundle. For example, while giving the posterior superior nerve block, there is a pterygoid plexus there. Using with a long needle more than 60 millimeter, what happen? It may be touch that pterygoid plexus of the veins. So it gives the more blood outside the vessels. So this is the main causes. Inadvertent nicking of the blood vessels is the main causes for the hematoma. How to prevent this? So know the normal anatomy. That is very important. We want to know the normal anatomy. Then only we avoid lot of complications. So modify the injection technique. So once we know this place having hematoma, easily some blood vessels thermate, we want to some other techniques. So we modify the technique. Use a short needle per PS. Already just now I told. So posterior superior block only 16 millimeter is our depth of penetration. That purpose we want to use the short needle to avoid this hematoma. Minimize the number of needle penetration. So we want to use correct anatomical landmark. So only one penetration we want to reach our target. Nice. Okay. Then only we can avoid multiple incision. Sometime maybe eating the some vessels. So never use the needle as a probe in the tissue. So multiple time using means needle getting probe. So it causes it may be eating the vessels. So management immediately. So once hematoma happen, how to manage? So when swelling becomes evident, we want to give the direct pressure applied to the site of bleeding. So it may be causes some more reduce the swelling. For example, inferior nerve block, want to apply the pressure in the medial aspect of the ramus. That region we giving means maybe the hematoma maybe became the less, not increasing the size. Infraorbital nerve block, we giving the pressure on the skin directly over the infraorbital foramen. It's directly we can give. Mental or incisive nerve block, we can create pressure in the mental foramen region. So buccal nerve block, we can give the pressure at the site of the bleeding. So where is the bleeding happens? The long buccal nerve. That place we want to give. PSA, posterior superior nerve block, we can give the infraorbital temporal spacer can accumulate large volume of the blood. So it's a big swelling coming. Digital pressure applied on the soft tissue in the mucobuccal fold of the directly as a tolerator. So we can give that mucobuccal fold region direct pressure. Subsequently, so these are the things we give that immediately. Then subsequently what you do? Do not apply the heat or for at least 4 to 6 hours of the incident, because we given the heat means more vasodilatation happen. Vasodilatation happen, more is increase the more vascularity that region. So swelling become more big. So hematoma is getting more big size. So please don't apply the heat for first 4 to 6 hours. If the patient having soreness develops, advise some analgesics. Discoloration, maybe bluish discoloration happen hematoma. So it may be resolves up to 7 to 14 days. Up to 1 or 2 weeks is taking. If limitation of the movement of the jaw develops, begin the treatment as a described for trismus. So patient having some movement restricted means it's a trismus. So I told already some physiotherapy, muscle relaxant, everything want to give. The warm moist cloth may want to give 20 minutes hourly. Apply ice pack to the region immediately. So immediately we want to give the ice pack. After that only we want to give the warm moist. You see everything, treatment everything by timingly only. Timing management. So immediately we want to give the cold pack. After 4 to 6 hours only we want to give the warm pack. So next complication is pain on injection. So what are the causes for the pain on injection? Careless injection technique. So patient getting more pain. So we without knowing the anatomy, so landmarks, everything we giving means it may be giving the more pain to the patient. Dull needles. Needle must be very sharp. Dull means is giving more while penetrating the mucosa and muscle is gives some fibrous getting more pain and fibrous trauma. That's why we want to avoid the dull needles. So rapid deposition of the solution. So every injection technique having the duration. So 1 ml want to deposit means you want to getting about 60 seconds. 1 minute want to take, slowly want to deposit. Otherwise rapid deposition that space getting more filling and only immediately is getting compression and the pain in the muscle. Needle with the bobs. So bobs needle must be avoided. These are the causes. How to prevent this? So proper technique of the injection. First we want to know that proper technique and anatomical landmarks, the target region, everything. And use sharp needles. Only one single use needles, sharp needles want to use. Use topical anesthesia period to the injection. To avoid this, we want to use some topical anesthesia gels in the mucosa to avoid the pain. Use sterile local anesthesia solution. So you want to use a sterile solution, not contaminated. And also slow injection technique. So 1.8 ml means you want to take the 1.5 minutes, about 90 seconds want to take to deposit the solution. Slowly want to deposit. Burning and injection causes because of the pH of the solution. So while using the local anesthesia solution, plain solution is about pH is a 5.5. But while adding the epinephrine we adding for long action. So it's getting pH getting very low, about up to 3.5. So it causes more burning sensation of the tissue, and also a rapid injection technique of the local anesthesia, and also contamination of the local anesthesia cartridges. So we using the epinephrine, we adding the epinephrine causes the decrease the pH of the solution, that causes the irritation to the tissue. That's why the tissue getting burning. So that's why we want to add the epinephrine is a less amount. Only per compare with the lidocaine epinephrine 1:1 lakh and 1:2 bupivacaine is 1:2 lakh is a more concentration of the epinephrine getting more burning sensation because of pH is getting very low, and also rapid contamination of the LA and contamination of the LA cartridges causes the burning sensation. How to prevent this? Slow injection technique, our local anesthesia solution must be in the room temperature. So after that, the patient having soft tissue injury also. Maximum soft tissue injury because of the maximum is having in the children. They getting, for example, lip getting numbness. So they think is a lip while biting the lip is not pain up to the local anesthesia action. So after some time, 3 hours after local anesthesia gone, epilepticus goes means patient getting more pain. So that we want to care the children. While giving the injection to the children, we want to make sure to take care of the soft tissue, tongue. They may be bite the tongue or they bite maybe the lip. Not only children and also mental retarded patients, physically handicapped patients, everything we want to extra care and want to take to avoid this kind of lip injury and tongue injury. And also infection. This is the next complication. So infection causes the contamination of needle prior to the injection. So that's why I told we want to clean the mucosa by using the antiseptic solution. And also our needle, everything is sterile. So that's why single use technique, single needle using for the single patient. Improper technique of handling the local anesthesia equipment. So equipment may be contaminated with some infection, may cause the infection. How to prevent this? We want to use the disposable needles. So disposable needles means only single use using. Properly care and handle the needles. So our sterile is very important. So sterile condition we want to handle the needles. Properly care for the handle of the cartridges. Not only needle, cartridges also with the sterile condition we want to use. And also properly prepare the tissue. So before injection of any patient, we must be clean that region with the antiseptic solution to avoid this kind of infections. So how to manage infection? So we want to give the antibiotics and pain management by analgesics and muscle relaxant and physiotherapies. Because for example, inferior nerve block, we usually giving the nerve block in the mandibular nerve. The time infection happens means patient getting the trismus, patient getting unable to open the mouth. At that time we want to give muscle relaxant and antibiotics because of infection the patient getting in trismus. And physiotherapy. So physiotherapy is a very important thing to relieve the infection by the trismus. Edema. So this complication happens by giving the injection by trauma during the injection. So infection, allergy, hemorrhage, injection of the irritation solutions. How does the trauma happen means while giving the injection, already told. So while giving the injection, it may be injury to the vessels. That may be causes the more bleeding. That bleeding may be give the more expansion, more compression on the nerve and also expansion on the muscles. So it gives edema. So infections, allergic reactions may be due to the allergic reaction of our LA solution also giving the edema. Hemorrhage already told. Injection of the irritation solutions. Okay, so contaminated local anesthesia solution also causes edema. How to prevent this? So properly care and handle the local anesthesia solution. We want to properly handle very correct sterile condition we want to handle. Use the ace traumatic injection technique. So sharp needle and a single disposable needles want to use with a good anatomical and our one of the target region. Complete and adequate medical evaluation is very important. This is very important for avoid the allergic reaction. That's why edema may be due to the allergy also happen. So that's why we want to spend the more time on the history taking. The time patient are already having some injection, the same local anesthesia solution or not. That time they are having any events, allergic event. So we want to more time spend on the history. That only gives our previous allergic history of local anesthesia solution. Management. So this edema resolves 1 to 3 days. Following the hemorrhage, it will resolve up to 7 to 14 days. Edema produced by the allergy is more life-threatening type. So this kind of edema due to the hemorrhage, it's okay up to 7 to 14 days is a resolve. But it's edema due to the allergic reaction is more life-threatening. Bronchospasm may be happen. That's why any patient first time they going for your local anesthesia solution like a lignocaine or articaine, you must give the test dose. So we want to give the test dose, want to check the patient any allergic to the particular local anesthesia solution, then only we want to give. Then okay, it's very important. If edema occurs any area where it compromises breathing treatment, consists of administration of epinephrine and corticosteroid. So if it happens, if allergy happens means you want to immediately want to treat the patient, bronchospasm, everything. So it's a life-saving drug is epinephrine. So your adrenaline is very important. So emergency drug trial you want to take, you immediately want to give the adrenaline and corticosteroids. These are the drugs want to give the patient to manage your allergy reaction. Then slapping of the tissue is causes because of epithelial disformation. Because of application of the topical anesthesia for prolonged period, it may be causes the epithelial disformation or heightened sensitivity to the tissue to the chemical agents, reaction in an area where topical anesthesia is applied. So our topical anesthesia solution, it may be causes epithelial disformation. It also causes sterile abscess by secondary to the prolonged ischemia, or as always occurs in the tissue to hard palate. This is mainly we can see the hard palate region because of the more vasoconstriction, everything. So we are adding epinephrine. So this kind of lesions we can see. How to prevent this? Want to use the topical anesthesia as a recommended. So don't use a more concentrated. So we want to recommended topical anesthesia only want to use to allow the solution to contact the mucosa membrane for 1 to 2 minutes only. After that you wash it out. When using the vasoconstrictor for hemostasis, don't employ overly to concentrated solution. I already told you, more concentrated solution gives more vasoconstriction. That way the local necrosis of the tissue happens, the epithelial disformation happens. So management. So this kind of lesions we want to manage by the symptomatic. So the epithelial disformation and sterile abscess maybe want to manage by the symptomatic treatment is enough. No need systematic treatment. Topically ointment such as a Vora base or minimize the irritations. So last one is a post anesthetic intraoral lesions. So some after injection patient coming with some lesions. So recurrent after stomatitis, herpes simplex, the viral lesions, and trauma to the tissue by the needle and LS solution. So these are the causes for the lesions after injection. So how to manage this? Primarily manage the symptomatic. This also we manage by the symptomatic treatment. Viscous lidocaine ointment, maybe you want to apply that on the lesion. Usually the mixture of equal amount of diphenhydramine and the milk of the magnesia rinse in the mouth effectively coat the ulcerations, and also Vora base ointment as a protective paste provide the degree of pain relief. So this kind of symptomatic treatment and the ointment is enough to manage this post anesthetic oral lesions. So this kind of lesions we can see after post operatively patient coming for review. So this kind of patient you want to manage by the symptomatic and this some the ointment, Vora base ointments. So thank you for watching. Thank you.